Hi, I am Heather Simonich. I'm an operations director at PATH of North Dakota, which is a community-based services and treatment foster care organization that's been around for about 20 years in North Dakota. I want to acknowledge that Jody Dudenheffer, who's also an operations director at PATH, was intending to be here but can't, and so I will give the presentation without her, which should go just fine. But I think before I start, I just want to acknowledge those of you that are either parent or sibling survivors or survivors yourself, and I just want to say thank you for your willingness to share your stories, to be part of the conversation, and to just extend, just sincere gratitude for your courage and vulnerability, because it inspires us to keep going, those of us that are trying to be the helpers. And so, thank you. So some of you might be familiar with PATH. PATH started in 1994 primarily as a treatment foster care provider in the state of North Dakota. And so Allison's asked me to just share some of the work that we've been doing, largely because of some of the funding from the Department of Health around suicide prevention as a whole organization. Just this past April, I threw this up there because recently a big change happened at PATH, and that was that we affiliated with what's called Nexus Behavioral Health, centered out of Plymouth, Minnesota. And so that was a big change for us, and I think through that process we've learned a lot about ourselves and where our strengths are and where we have challenges and room for growth. And so I just mentioned that as also an acknowledgement of a group of folks that are really supporting the work that's getting done at PATH around suicide prevention. So PATH, although largely known for our work in treatment foster care in the state of North Dakota, we have about 480 individual foster parents, translating to about 300 homes that serve as treatment foster care providers every day for some of our most vulnerable youth in the state of North Dakota. But we also provide some community-based programming that are certainly the programs that are aimed at keeping kids in their homes and preventing out-of-home placement. Things like our family support program, some contracts with the Southeast Human Service Center that again target youth and work diligently to maintain relationships in homes so that youth can stay at home where they are most able to be resilient. We recently started the PATH Trauma and Stress Clinic, outpatient mental health services really aimed and targeted at serving kids and their families who have experienced traumatic life events. I mentioned treatment foster care. We also, in collaboration with Catholic Charities of North Dakota, are administrators of the Adults Adopting Special Kids programming, so that's any adoptions that are happening out of our child welfare system, in addition to coordinating the Chafee Independent Living Program for the state of North Dakota, which serves to support youth transitioning out of the child welfare system and out into the great big world. And that can be a really difficult and challenging transition, as we all know. So PATH has 9 offices across the state of North Dakota, but we also have treatment foster care in the state of Idaho. I don't think I probably have to speak to this group for very long to really make a case for why suicide prevention is really important at PATH. The research is clear about the risk level of children in the child welfare system. So at PATH, our mantra is not about trying to determine if a kid is at risk for suicide. The assumption that every child we serve, especially in treatment foster care, is at risk. It's not if, it's at what level are they at risk of suicide. We know that children in the child welfare system are at increase for multiple mental health problems, and research has found that many mental health conditions, of course, are strong predictors of suicide attempts and completion. Being a victim of maltreatment, of course, increases the odds of suicide by approximately 4-fold, and the odds of attempts at 13-fold. So we work in a system where we have high risk for suicide. Children placed in foster care in terms of their involvement in the child welfare system are at even greater risk, with suicide rates or attempts reported between 8 and 15%, which is 3 to 9 times higher than the general population. And according to the North Dakota Department of Health, Native American children are 333% more likely to commit suicide or die by suicide compared to Caucasian youth. And that's a relevant statistic for us at PATH because 42% of the children that we serve in treatment foster care are Native American youth. Youth at PATH have an average of 2 mental health diagnoses when they come to us and have had an average of 2.3 prior out-of-home placements. I mentioned 42% are Native American. Children in PATH care report an average of 6 ACEs. So thank you to those of you that have referenced the Adverse Childhood Experiences Study. At initial placement, our case managers work with the child's team to get an assessment of their exposure to traumatic life events. And so we do that with all of the children placed at PATH. And the average is 6. And I'll show you some data too on my next slide about how that shows up in terms of each type of traumatic event. I'll also note that when we look at our youngest children at PATH, which a lot of times people think about treatment foster care as a service that's working with really difficult adolescents. And while that might have been the case when we first started, we now serve about 45% of the kids in treatment foster care are under the age of 8. And so what's alarming about the ACE data and our youngest children is that when you actually just look at our children under the age of 8 at PATH in treatment foster care, their average ACE score is 8. And so our youngest children have the highest rates of trauma exposure based on the ACE survey. Those who have had at least one adverse childhood experience, of course, are at increased rates for suicide attempts by 2 to 5 times, and those who experience 4 or more ACEs are 12 times more likely to die by suicide, or to attempt suicide, I'm sorry. And so knowing that our children have an average ACE score of 6, that statistic is really relevant for us. This is the 10 different types of ACEs, if you're familiar with the Adverse Childhood Experiences Study. So you have psychological abuse, physical abuse, sexual abuse, emotional neglect, physical neglect, caregiver abandonment, domestic violence, witnessing domestic violence, caregiver substance abuse, or caregiver mental health, or serious mental health or mental illness and suicide, and then an incarcerated family member. The orange bar is the original ACE study that really, again, is the foundation of much of our conversation in this country around trauma-informed care. The red bar is our youth at PATH that were placed in the year 2016. And so you, again, can see how significant their trauma histories are and therefore clearly at increased risk for suicide. So thank you, Dr. Taylor Desir, for talking about the Zero Suicide Framework. That's been, I think, a really helpful approach for us as a whole organization to think about this as a comprehensive effort that, again, starts kind of at that front desk and goes all the way into our PQI type process or quality improvement type processes at PATH. We use these 7 guiding principles, again, or areas as a framework for us to dive in as an organization and figure out, again, where our strengths and our needs are, and I'll talk about how we did that here in just a minute. The first thing that we did was, in order to engage our administration, which we found, or which we all agreed was critical in order for us to do this as a whole organization, not just here frontline workers, we're now going to screen for suicide. We knew that we needed our administration bought in, which wasn't too hard, but I think it was helpful to give them the opportunity to complete a self-study. And I share this because all of these are free resources on the Zero Suicide website that any organization can download a PDF and complete the Zero Suicide self-study as a leader in your organization, and it just really makes you think comprehensively about what kind of work you need to do in terms of suicide prevention. We then secured a contract with the Education Development Center, which is the kind of home of Zero Suicide, and so that we had a consultant that worked with us for over a year to help us do this as a whole organization. And I'll note that this was the first time that Zero Suicide had ever been contacted by a behavioral health provider. Largely their work has been with healthcare providers, large healthcare providers like a big Sanford. Never before have they worked with necessarily a behavioral health provider or especially child welfare driven organization. So part of our contract with them was to work through adapting their materials to work in a behavioral health setting versus a traditional healthcare setting. So then we went on to create and modify the Zero Suicide, or we created the Zero Suicide Implementation Committee to have steady leadership guiding this effort, and then administered the Zero Suicide Workforce Study, or Survey. And what I will say to you, for those of you that are leaders in organizations doing work with any individual struggling with suicide, is this was an eye-opening experience for us. So this survey went out to all 100 of our staff across the state of North Dakota on a SurveyMonkey link, and it went to all of our foster parents in the state of North Dakota. And we had about 300 respond to that survey, and it was a comprehensive survey of about 60 items, assessing and really being vulnerable and looking at how do we do suicide prevention at PATH? What do our foster parents know about suicide in general, and what do our staff know? And what we found is we had a lot of work to do. It was loud and clear and screaming, and we would have been very negligent to ignore it. But boy, did it drive how we approached the work, and it was easy to get buy-in because it was driven by the voices of all of our foster parents and our staff saying, we need to do this more effectively. And the big themes that came out of that survey were, we need to help foster parents recognize the signs of suicidality in youth. We need to screen and provide better intervention for suicide risk. And we need to make significant improvements in policy and procedure for all of those things. And that drove kind of how we've gone about our work. This is an example of one of the many questions, but we went through every question on that survey. And this is the one that about dropped me over, was to ask all of our folks, you know, have you had training in suicide prevention? And keep in mind, we are serving North Dakota's highest risk youth in so many ways. And yet, on average, we got maybe a 2 out of a 0 to 5 point scale. So 2 being disagree. And that spoke loudly to us about all the work that we had to do. So again, and you can see how we broke it down to look at that by administrative staff that respond, foster parents, case managers, and then middle management. So we started with a site visit from Zero Suicide. The consultants actually came to North Dakota, and that training was a one-day training targeted mostly at leadership within the organization around the Zero Suicide framework. And importantly, at that meeting, we spent about 2 to 3 hours laying out a strategic plan around suicide prevention, both in the immediate goals and plans, but also future goals and plans. And then I think one of our biggest challenges was to go through all of our policies at PATH and comprehensively review not only how we're handling youth that might have a suicide attempt or die by suicide, but also how are we have encountered and dealt with suicide in our foster parents and our staff. And none of that was really addressed thoroughly in our manuals in terms of policy and procedure. It's remarkable, actually, to me, as a licensed organization in the state of North Dakota that is a child placing agency, that there aren't more significant requirements around suicide prevention policy. Then we had to develop a training plan for our staff quickly, and we needed to get it out there, and it needed to be sustainable. So not only the 100 staff that work for PATH, but this huge and fluid and diverse and rural and urban group of foster parents that we had to figure out how to get some consistent training to. And so you can see here I just noted some of the dates that we held training. We identified the Connect model for training. We considered things like assist and safe talk, and what we really felt was needed was we felt were some of the downfalls there were some of the lack of flexibility and kind of the canned approach, and we wanted a little bit more adaptability and flexibility in what that would look like when you're working in such a dynamic field as child welfare. And so we went with a Connect model, it's called, and have rolled that out as a gatekeeper training to foster parents and also to staff. Additionally, trained some trainers to be able to sustain that within our turnover, new employees as they come on board. That's the website for the Connect suicide prevention model and work, and it's really a community-based model that doesn't focus just on an organization, but the necessity of having the community, the whole community on board. Importantly, just in January, as of January 1st, we have started screening routinely all of our youth, which prior to then we had not done in any routine fashion, using the Columbia Suicide Severity Rating Scale, so at least assuring that this conversation is happening at some level with all of the children that we are working with. And I just want to point out, I know Rory Beal is here and isn't speaking today, but largely because of some of the work that's been happening with the Rethink Mental Health Group in the Fargo-Moorhead community, many of our providers, our healthcare providers, our first responders, our PD, our schools, have got on board with using the Columbia, which has also been really beneficial in communication and common language, given our child welfare kids are surrounded by such a diverse team of professionals. It's important for us to have common language when we're trying to assess suicide risk and assure that we're getting our children the appropriate level of service. Performance and quality improvement was a big part of this initiative. And this is an initiative, by the way, that won't be done this year and it won't be done next year. We really see suicide prevention as work that is an ongoing thing, similar to trauma-informed care. But PQI is an area where we now have in our electronic health record, we have created a whole bunch of different ways to document and study suicide, not only attempts, but certainly deaths by suicide. And not just while children in our care, but even in our independent living program or adults that are coming back home to visit with foster parents that still have connections. We used to, in our critical incident reporting, hospitalization was the category that we documented suicide attempts under. And so if somebody were to ask us at PATH, how many suicide attempts did you have in the last year? We wouldn't be able to tell you because it was all lumped in a category of hospitalization. So whether that was for suicide or whether it was for some sort of medical injury, they were all lumped together. So now we've all got that broke out so that we can accurately report suicide attempts. And then importantly, one of our next steps is going to be sharing some of this work with our partners and stakeholders in the child welfare field. We believe that it can't just be PATH, it can't just be our schools, it can't just be one of our groups of folks, but that we have to have everybody together working in the same direction. And so we will certainly be sharing out this information not only in settings like this, but in some more formal writing and conference presentations. So I just want to acknowledge the North Dakota Department of Health for your funding and your support in this work. Without that funding, I think it would have been difficult for us to dive so deeply and comprehensively, and in the long run, we are in such a better place because of that support. And so I would happily take questions if you have any, otherwise my time is about done here, so. Thank you.